original Mysore Parks. I think it is kept there. You can have them. So this is not something that I've experienced. This is just I've started trying. I had gone for a training in Barcelona for the minimal access and started adopting it for diabetic foot. They were teaching it more from the podiatric perspective for metatarsalgia and various hallux valgus and other aspects, and started adopting it thanks to Madhu, because of the inspiration of preventive offloading. I got an idea, why can't we use this for diabetic foot? And if you have questions, complex questions, I don't have answers because I've just started trying it for about 20 cases since September is what we have done, and few of the cases is something I'm showing. Just the before and after pictures and the x-rays of what we have done. So these are the two cases that we have been we'll be showing right now, and this is the instrumentation that will be required. Simple bevel plate, that's the Arthrex machine that I have bought, and we've been using that. And a small Siam, what is that? This doesn't require an LED apron and all those things for this. It can be done at an OPD level under regional blocks. Even if you have an ankle block, these procedures can be done. This is an explanation of the procedure where we just do a 3 mm incision with that bevel blade, and then use the Shannon burst to kind of go into the bone either from medially or from dorsally, and then do the osteotomies right then and there. And the dressing or the bandaging is the key here in terms of for the realignment or the union of the bone later on, apart from making him walk from the just post surgery itself. The way you dress is the key, where it is kind of done it as a ripple over the toes. I'll not run through the whole thing, and the good part of it is not being so bold enough to put him on the walking immediately. Probably going further I can do it.
No, it's actually advisable you make them walk out.
That's a floating osteotomy.
It's a floating osteotomy. The longer you keep them rested, the care.
No, walk is fine, but with the slab I make them walk.
Yeah, that's fine.
Yes, with the slab I make them walk, but the recommendation where I learned was like make them walk
Actually,
immediately.
you don't need a slab for this because you want the osteotomy to move.
Yeah.
So you can just, and you got only a puncture wound
Yes.
earlier in the walking, but maybe, but if they are on antiplatelets or something just to prevent that.
Yeah, I haven't seen much of a bleeding or anything. It has healed without even a suturing. It has healed kind of a thing. So this was the wound that we saw, and after about 4 months. And this is the X-rays that we saw. Osteotomy of the first metatarsal with the 20 mm Shannon dorsal displacement.
I just one comment about a distal osteotomy in the first metatarsal. Usually we prefer a proximal osteotomy in the first metatarsal because the first metatarsal is the only metatarsal that has a flexor, dedicated flexor. So what happens is sometimes if you do this, see, we always think that the length of the metatarsal is important for it to dorsiflex. So when you do a osteotomy, if you are slightly careless, you do an osteotomy here, then what happens is this part will start to flex and that will go up. So usually distal osteotomies, we are a little careful. If we do it, we always prefer to fix it.
Okay.
And usually only for hallux valgus, the seri transfer will
So in this, they are keeping it floating.
Yes.
Yes, this is all floating, sir. There's no. You can also fix it with minimal access.
Yes.
There are
Yeah,
lot of
Yeah, from the front you can do that. And this was another ulcer. There was an ulcer like this. This is immediately post debridement. You can see the small incision, some blood here. That is just the incision that we have taken for a minimal access. The wound we had put a dermacell and that healed completely, but this is how it has been healed, and this is the floating osteotomy that we did with the minimal access. This is more of a proximal diaphyseal osteotomies that I did. The PPX osteotomies, again, there was an ulcer here, and we did a PPX osteotomy did, and then we see the wound heal. I didn't find the lesser toes. Again, this was the most recent one, I suppose. So there was a non-healing ulcer here with a cavity P2B was positive, no osteomyelitis or anything. So we did both the toes osteotomy was done, and then we see a healed ulcer at about 2 months time frame. There's a few more pictures of pre and post-operative osteotomies with a 3 months follow-up that we have been seeing, and this is the 4-month follow-up with the pre and post-osteotomies. Last osteotomy, I don't have the wound pictures here. Yesterday I was trying to get it from my nurse, and it was a bit of a challenge for him to send it, so I don't have the wound pictures, and this is the 5th toe osteotomies that we did, and the wound has been healed. It's safe procedure. We'll have to start doing it. There has been improved outcomes, as I said, walking, there is no rest period and other things, and that's about it, and a few of the sources that I have used this for. Thank you.
Can you show the first slide, please? The
And
requirement.
Sanjay, request you to give us some Shannon bars.
Sure.
But it requires
They've got a
Within 10 days before investing 25 lakhs.
Yeah,
When it comes to ROI, that doesn't work in my
If I
sector.
go to a corporate hospital, I get everything except for the birth.
You will have rest of the things are available. What you need is that high rotation burn and a small hand.
Exactly.
So Sanjay,
So the burn is about, I think is about 10-11 lakhs.
Incision is only.
And the CM is
That's all. That's all.
Very buoyant, that's all.
That's all. It has changed the way everything's done.
Indian system comes for 4.5 lakhs similar, and most of the podiatry surgeons like Dr. Sampath Patil or might be, I don't know about Dr. Munot, but those who are peripheral, Dr. Girish Motwani in Nagpur, we all are, I am not using, but they have got Indian system that comes at 4.5. But I know Sanjay, he will always go for the best in the market.
So now suppose you don't have this, what Madhu I have seen is they take a vertical incision and just do the.
Overall muscles is also
ओपन
small.
कर सकते हो, ओपन करने में कोई प्रॉब्लम
It
नहीं
is
है।
doing laterally open and.
I am in
सर
a,
ये
sir,
स्पीड में होने वाला प्रोसीजर है सर।
like in a closed door, I am in a
याद रखो।
private setup. I have to have an MS,
Yes.
you know.
ये वाइट फील्ड में होने वाला प्रोसीजर है, KIR में होने वाला प्रोसीजर नहीं है
He
ये।
has to, he has to maintain his flat position by offering something new every year in the market.
Yeah.
Yes.
I have to keep it up and saying that, you know, I do this. When patients go to multiple people, I have to see that I do it in minimal access where you do not even, you know, have a,
Stage
like
also.
just an